Good morning, everyone. Welcome to the Nagara National Seminar. I would like to invite our paper presentation coordinator, Dr. Aishita S. Hello, Dr. Aishita.
Thank you, Dr. Sabin. So, a warm good evening to one and all, and welcome to the final day of Nagara, national level seminar with paper and poster presentation presented by Team Ayurapta. So, first of all, let me invite our esteemed faculty members. And first, I would like to invite Agadandra panel, Dr. Sri Lakshmi SG, Dr. Rina R, and Dr. Shankar Raj. Next, I would like to invite Panchakarma panel, Dr. Rajnisha K, Dr. Pramila K, and Dr. Sukanyasa. Now I invite Devyaguna panel, Dr. Bindu Pillai, Dr. Sridevi, and Dr. Shija. I invite Kaumara Bhrithya panel, Dr. Shrija Ashok, Dr. Ramya, and Dr. Ansiba. Let me invite Samhita panel, Dr. Veena Vijay, Dr. Rashmi H, and Dr. Krishna Priyasi. I welcome Nidana Tantra panel, Dr. Srilata Soman, Dr. Nitya R, and Dr. Arya K. I welcome Prasuti Tantra panel, Dr. Kumari Velayudan, Dr. Kavita, and Dr. Ashwini K. Now I invite Swastavrita panel, Dr. Indira Menon, Dr. Shilpa, and Dr. Kirti. Let me invite Kaya Chikitsa panel, Dr. Madhavan, Dr. Vinita S, and Dr. Surya Chetak. Now I invite Manasika panel, Dr. Nidin Darade and Dr. Umar Jadhav. Now I welcome Shaladandra panel, Dr. Vaishak Emman, Dr. Ravita Singh, and Dr. Pratibha Somraja. I welcome our Rasa Baishija panel, Dr. Arulal K and Dr. Preeti. Now I invite Shala Kitantra panel, Dr. Krishna Prabha, Dr. Devika Pratap, and Dr. Revadi Raghu. Now I invite Kriya Sharira panel, Dr. Kiran Kumar T and Dr. Remya. And I welcome Rajna Sharira panels, Dr. Roshli Raghav, Dr. Remya Bhushan, and Dr. Divya Prabhaji. And before get start, I wish all the very best to each and everyone. And dear participants, let me remind the rules and regulation that should be followed during the presentation. You have maximum time period for the presentation is 8 minutes. So kindly follow the time limit. And the presentation will be live on YouTube and copy saved in broadcast. So don't unmute unnecessarily. Now we can start the session with a paper presentation. And I invite Dr. Gururaj Patil for the paper presentation. I invite Dr. Gururaj. Dr. Gururaj, please unmute yourself. Dr. Gururaj. Doctor, you are not audible. Dr. Gururaj.
Hello, Dr. Gururaj. We can't hear your voice, doctor. Hello, doctor. Please reconnect your headset, doctor.
Doctor, your screen is visible, but you are not audible.
Hello, Dr. Gururaj. We can't hear your voice, doctor. Doctor, please reconnect your headset, doctor. We can't hear your voice, doctor. Hello, Dr. Gururaj. Can you hear me? Hello, Dr. Gururaj. Can you hear me? Okay, we will call you next, Dr. Gururaj. Next, I would like to invite Dr. Trisha Rai for the paper presentation. Dr. Trisha, are you there? Hello, Dr. Trisha Rai, are you there?
Hello, sir. Hello, am I audible?
Yes, doctor. Audible, doctor.
So please display my PPT.
1 second, doctor.
Yeah.
Hello, Dr. Trisha Rai. Please start the session, doctor.
Yeah. Hello. So this one is not my updated PPT.
Okay, 1
Hello.
second. Okay, 1 second.
Yeah, sure.
Please start the session, doctor.
Yeah. Hello. Good evening, everyone. Myself, Dr. Trisha Rai, and my HOD's name is Dr. Neeta Kedar, Shalya Tantra Department from Government Ayurvedic College, Nagpur. So my today's topic is hypertrophic scar and keloid wound complications. These two are very similar, very confusing, and clinically little bit difficult to distinguish. So we are going to see few wound complication. So rather than hypertrophic scar and keloid, we can see there are other wound complications are also, like most commonly that is wound infection, wound dehiscence, and in deeper wound we can see paresthesia, ischemia, and paralysis. Next slide, sir. So first of all, we will read about keloid. Keloid is excessively abnormal. Actually, keloid and hypertrophic scar both are due to excessive collagen formation. Formation of collagen is excessive in both in keloid and hypertrophic scar. So keloid is abnormally stretched type 3 thick collagen tissue bundle arranged with alignment in same plane of epidermis, but it extend beyond the skin beyond the scar margin, and it goes toward normal skin also. Defect in maturation and stabilization of collagen fibers. Normal collagen bundles are absent, and they grow for longer period, continue to grow even after 6 months, for years also. It is common in blacks and dark skinned people, mostly in Africans and in females. It is genetically predisposed, often familial, and it is rare in Caucasian people, North American, or white people. It is brown. Its clinical features are that it is brownish black or pinkish black due to vascularity in color, and it is painful, tender, sometimes hyperesthetic, spreads and cause itching. It may be associated with Ehlers-Danlos syndrome or scleroderma, where skin become elastic shape. Spontaneous keloid occur following an unnoticed trauma without scar formation, and pathologically, keloid contains proliferating immature fibroblast or proliferating immature blood vessels and type 3 thick collagen stroma. In Ayurveda, Vagbhatacharya described it as Vran Granthi. As per Vagbhat, it is not a curable condition. So these are few common sites of keloid. It is most commonly seen over sternum and mostly in butterfly shape, upper arm near shoulder, chest wall, and lower neck in front. The differential diagnosis are hypertrophic scar, which we are going to see. And dermatofibroma is another differential diagnosis where it is also known as benign fibrous histiocytomas of skin. It commonly occur cutaneous entity, usually centered within the skin's dermis. Next slide, sir. Here you can see a few commonest site of keloid, which is over sternum and ear and upper arm near shoulder and in belly. Next slide, please. So first we are going to see the treatment. First line of therapy is steroid injection. Intrakeloidal triamcinolone, which is a steroid injected at regular interval of 7 to 10 days for 6 to 8 times. So triamcinolone is a corticosteroid. It reduces fibroblast proliferation and collagen synthesis. Silicone gel or silicone gel sheeting is also used. Methotrexate and vitamin A and C therapy is used. Methotrexate, topical retinoids, vitamin E, and palm oil massage. Intralesional excision, retaining the scar margin, prevent recurrence. It is because keloid is very much chances of recurrence, so we can give intralesional excision by retaining the scar margin. Here are images of intralesion excision, and we can also use laser therapy, anti-ag laser, or cryotherapy. Next slide, please. Interferons may be also useful, and triple therapy 5FU, that is fluorouracil local injections or steroid injection and laser. Triad of treatment at a time is also given. 5-fluorouracil and bleomycin local injection is also given. And steroid injection, excision, and then again steroid injection. And excision and irradiation or irradiation alone. Excision and skin grafting, which is not that much ideal, but few people do that if the scar margin is a little bit wider. Excision and primary suturing has also a high recurrence rate. The most commonly first line of therapy we use is steroid injection, intrakeloidal triamcinolone. Next slide, please. So now we are going to see about the hypertrophic scar. It is excessive formation of abnormal scar tissue containing type 3 thick collagen. But here we see thin collagen, which is raised, often vascular, confined within margin of original wound or scar, will not extend to normal skin. Common in wound crossing tension line, deep dermal burns, or wound healed by secondary intention. Growth stop in 6 months and often regress spontaneously, not genetically predisposed, not familial. Spontaneous improvement with time occurs commonly, self-limiting, pale brown in color. It is not painful, not ending, doesn't cause itching, and recurrence is uncommon. Next slide, please. Site is all over the body. There are no specific site like keloid. Some of the diagrams of the hypertrophic scar. Treatment, it is controlled by pressure garment, excision of scar and closure if requires skin graft. And second line of therapy is triamcinolone injection. Hypertrophic scar also respond very well to steroids. And complication are often the scar breaks repeatedly and cause infection and pain. After repeated breakdown, it may turn into marginal incisor. Next slide, please. Now, there are a few differences between keloid and hypertrophic scar. How we will differentiate these things? So, first is genetic predisposition seen in keloid, not in hypertrophic scar. Site of occurrence of hypertrophic scar, as we see all over the body, common in flexor surface, and in keloid, chest wall, upper arm, lower leg area. Growth is continuous without time limit in keloid and limits for 6 months in hypertrophic scar. It extends to normal skin keloid with type 3 thick collagen, and it limited to scar tissue only with type 3 thin collagen. Treatment has keloid has poor response because it has high chances of recurrence, and hypertrophic scar good response to steroid. Collagen synthesis is 20 times more than normal skin, and in hypertrophic scar there is 3 to 6 times more than normal skin. Relation of signs of injury, size of injury and lesion, no relation. Small hit scar can form large keloid, and hypertrophic scar is related to site of injury and duration of healing. Age, keloid we can see in adults and in middle age, and hypertrophic scar we can see in children. Next slide, please. Keloid is common in females, and hypertrophic scar has no sex boundaries, so it is equal in both. It is more in black 15 times, and it is no racial relation. Structure thick collagen with increased epidermal hyaluronic acid, and hypertrophic scar fine collagen with an increased alpha actin. Alpha actin is a very important protein in our muscles. Features are vascular, tender, and itching of keloid, and not vascular, non-tender, and non-itching. In hypertrophic scar, it is progressive and shows regression. And complication are hyperstasia and ulceration in keloid. And hypertrophic scar has that not much complication, as we can see keloid scar and hypertrophic scar close diagram. Next slide, please. These are few references. Next slide, please. Thank you so much, everyone.
Thank you, doctor. So next I invite Dr. Rina.
Yes, I am here.
Good evening, doctor. Doctor, please share your screen.
I am connecting. Just wait. It's not connecting actually. Can you help me out?
Don't worry, doctor. I will share for you, doctor. Please start the session, doctor.
Am I audible?
Audible, doctor. Please start, doctor.
Okay. First of all, myself Rina Malunjkar from GAC Nanded, Sira Shaareera department. Today's my topic is ADHD. ADHD is the attention deficit hyperactivity disorder. What is ADHD? First of all, a pattern of diminished sustained attention and high impulsivity in child or adolescent than expected for someone of that age and developmental level. There are 3 types: combined level, predominantly inattentive type, and third one is predominantly hyperactive impulsive type. Now, what is ADHD? Attention deficit hyperactivity disorder. As usual, already said, it's a persistent dysfunctional level of inattention, hyperactivity, and impulsivity. These are all combined in ADHD. That means attention deficit hyperactivity disorder. In this, there are 6 or more symptoms oftenly present. First of all, inattention to detail, careless mistakes, Second one is trouble making attention on task. Third one is doesn't seem to listen when spoken to. Fourth one, fail to follow instruction or complete the task. Fifth one, uh, trouble organizing activities. Six, dislikes things that take prolonged mental effort. Seventh, loses things. Eight, easily distracted. And nine, forgetful. These all are 6 or more symptoms are oftenly present in ADHD. Then hyperactivity and impulsivity. What are these including? In hyperactivity, fluids in sit, but in impulsivity, blurts out answers before question finish. Then hyperactivity, there are loose sit, restlessness, runs, climb around inappropriately, can't be quiet, on the go, talks excessively. These are all included in hyperactivity. But in impulsivity, blurts out answer before question finish, does not wait turn, and interrupts others. These are all things included in hyperactivity and impulsivity. About 2 millions of more than 6 million children with ADHD were diagnosed as young children aged 2 to 5 years. Causes of ADHD. First of all, it's unknown. Causes and risk factor are under study. But there are also some things like genetics, neurobiology, or some other investigations, or some by researchers. There are 3 types of ADHD based on their symptoms. First of all, inattentive type, where the person can't seem to get focus or stay focused on a task or activity. Second one, hyperactive impulsive type, where the person is very active and often act without acting. And third one is combined type, where the person is inattentive, impulsive, or too active. There are symptoms mainly are inattentiveness. Second one, hyperactivity and impulsivity. These are basic 3 symptoms. The general signs of ADHD: the child is restless, then overactive, the child constantly chattering, child is inactive. That means then the lifetime course of ADHD symptom hyperactivity impulsivity domain में आता है. ये सब childhood adulthood में क्या क्या differences आते हैं, just like that. Then treatment of ADHD, we can cure ADHD by medical treatment or behavioral behavior, how to behave like this, and via educational, about ADHD and about educational interventions. How is ADHD treated? Behavioral therapy, training for child and parents and teachers, via medicines, some medicine stimulants or the non-stimulants or antidepressant can be treated by them. Then via education about the condition and symptoms of programs or support program, we can educate children, parent, or the social family. Then combining therapies is the most effective one. Behavioral strategy, first of all, improve study techniques, then social functioning and organizational skills. Tips for parents: provide clear, consistent expectations, provide clear, brief instruction, guide behavior with incentiveness, praise rewards and consequence. Then help stay organized, belongings, school stop and schedules. Then we can also tip to parents that limit distraction in the environment, use support group, that means connect to other families with ADHD needs. Then consider talk therapy for entire family, like get past frustration and other negative emotions. Sir, please show me slide number 15. 16. Developmental concern. Now, developmental concern. peer relationship difficulty, aggression, withdrawal, then rejection, not making friends. These are peer relation difficulty that development should be concentrate on this. Then academic difficulty, disruption, poor performance are included in academic difficulty. These we have to concentrate to develop in this. Then risk for injuries and or accident. Then not paying attention. Child is not paying proper focus or attention. That's why it increases the injuries and accidental traumas, not considering consequences. Other coping strategies like adequate sleep, adequate nutrition, and special ed services. Then ADHD, Ayurvedic Chikitsa. We can treat ADHD via Ayurvedic Chikitsa. In Panchakarma, we can treat it by Shirodhara or Nasya. And others also Aushadhi Kalpa are there, that mean Vachadi Sarpi, Kushmanda Sarpi, Panchagavya Sarpi, Ashwagandhadi Sarpi, and Brahmi Sarpi. Now I'm going to just short summary. What is ADHD? ADHD is there is inattention, hyperactivity, and impulsivity. In impulsivity in this ADHD, lack of these things. 6 symptoms explained before. 2 settings, 6 months, cause is unknown. Then impaired social functioning is there. Structure, incentive, clarity, brevity, and no combined behavior therapy and medication is the best therapy in ADHD. That's all. Thank you.
Thank you, doctor. Next, I invite Dr. Uma B. Gopal.
Hello.
I invite Dr. Uma.
Hello.
Hello, doctor.
Good evening, ma'am. Can you hear?
Yes, you are audible, doctor. Please share the screen.
Okay. Is it visible, madam? Screen is
Yes,
visible?
Doctor, visible, doctor. Screen is visible, doctor.
Okay. So, good evening, respected chairpersons. So, today I am going to present the topic Regional Anatomy of Indrabasti Marma and its clinical implication. So, the knowledge of Marma dates back to Vedic period. It signifies the vulnerable vital point where biological molecules of life are sensitive, and if damage causes grievous effect or a part or a body. So Marma is classified on the basis of structure, region, prognosis, dimension, and number, and is available in Ayurveda literature. So in classics, we get the description regarding 107 Marma. So the characteristic features of Indrabasti Marma as per the classical description goes like this. It is a Shakagata Marma, Kalantar Pranahara Marma, Mamsa Marma 4 in number. The injury effect is Shonita Kshayena Maranam, and the detailed explanation of the anatomical structure is not mentioned. That's why we have taken it for the research. So material methods goes like this. We have followed the Cunningham's manual for the purpose of dissection, and we have taken the 3 cadavers in the department of Sira Shaareera, and it was layer by layer dissection was conducted, and based on the location and anatomical structure of Indrabasti Marma, were determined on the basis of cadaver dissection and regional anatomy with the help of literary and observational study. So now we will go for the, after the dissection, now I am going to showcase the layer by layer dissection of the related to the Indrabasti Marma point. In the flexor compartment of the forearm region, the important anatomical structures observed are the flexor group of muscles, radial artery, ulnar artery, anterior-introitious artery, anterior-introitious vein, and the median nerve. So in the figure 1, you can see that we are measuring the length of the forearm. It is actually not said in relation to the forearm. It is said related to the leg, that we have to take the 12 angular pramana from the heel upwards, and that exactly lies in the center of the calf region, that is Janga or Madhya. Like that, if we take in relation to the upper limb, it is in between the Manibandha Sandhi and the Kurpara Sandhi, that comes in the center of the flexor compartment of the forearm, and that is exactly it lies at the center where there will be the muscles of the cubital fossa are coming in approximation with each other. And in the lower figure number 2, you can see the approximation of the two muscles of the cubital fossa forming the medial and lateral boundary in the form of pronate teres. And the second point tells you about the point of Indrabasti Marma, where they intersect with each other before they are going to get itself inserted. The lateral one is the brachioradialis muscle. The structure seen in the Indrabasti Marma point is in the Urdhva Shaka. You can see in the figure number 3, brachioradialis, the flexor radialis muscle, palmaris longus, and flexor superficialis. So in the figure number 4, you can see after the exposure of the muscle, we have come across the median nerve. And then in the figure number 5, radial nerve, radial artery, median nerve, ulnar artery, and ulnar nerve. So in the figure number 6, flexor pollicis longus, flexor digitorum profundus. So that the flexor compartment of the forearm is made up of bulk of muscles, which is internet connections unstable. Okay, so a bulk of muscles wherein it is the morphology is so created that it has to protect the underlying neurovascular structures. So in the leg region, in the posterior compartment of the leg, exactly at the terlangula above the heel. Okay, so the center of the leg region, posteriorly calf region, what we call it as, the structures which are seen in the gastrocnemius and the soleus muscle with its venous sinuses, exactly the deep to it, there was the posterior tibial artery, the peroneal artery or fibular artery, tibial nerve, flexor hallucis longus, tibialis posterior, flexor digitorum longus, which are the deep muscles in the calf region, in the leg region. So here you can see the structures one by one, layer by layer dissection we have done related to the Adoshaka, and the skin has been flapped, okay, in the first figure, 7th figure. And in figure number 8, you can see the two bellies of the gastrocnemius, the medial and the lateral head of gastrocnemius. And the red color pointer points to the Janga Madhye. That means what? The point where there is the muscular component of the gastrocnemius is intersecting or continuing down as the tendinous part, and the tendon, what you can see, the Achilles tendon. In the lower figure, you can see the dermatomes which has been painted. So deep to it, you can see the soleus muscle deep to the two gastrocnemius. The soul-shaped muscle is the gastrocnemius, which is also called as the peripheral arch. Okay, and green color that is painted is called as tendon of plantaris muscle. The section of the soleus has been taken. You can see the openings there at the peripheral heart where the blood passes out. So as most of the time we will be in a sitting or a standing position, it has to, there are sinuses where the temporal in the muscular movement, it will be pushed upwards. And those are the venous sinuses of the soleus muscle. So now we'll go on for the discussion related to the Indrabasti Marma and its clinical implication. It's a Kalantar Pranahara Marma, it is Afangla Pramana, Mamsa Marma, and Ardangla Pramana. So if any injury to the Mamsa Marma occurs, it will lead to continuous bleeding, blood that is more thin and watery in nature, causing pallor due to loss of blood. The Pandutva is nothing but due to the insufficiency of the blood because of injury and bleeding. Further leading to Indriya Gnana. So when the blood is lost, the sensation is also lost, and the nerves degenerate, and there is Indriya Gnana, loss of perception of senses, and there will be death. So it's a Kalantar Pranahara Marma. If at all it is treated, they are not going to die, and they can pull on the life for 1 month. So location of Indrabasti Marma in the lower limb. As per the reference available, it is situated in the middle of the calf. What I told you, that is the Janga Madhye. Okay. So in the upper limb, in the site of Indrabasti Marma is taken as that of Adosha. And accordingly, the forearm region, which lies between the Kurpal and Manibandh. This also I have told you, it's a midpoint was pinned, it is counterpart of calf region in the upper limb. So discussion goes like this, based on structural entity. What is structure? Mamsa Sira Snayu Asti Sandhi, it is a Mamsa Marma. So predominant component which you can see in the Indrabasti is Mamsa Marma, and it goes in favor of the observation of the lower limb. Why? And why it has been categorized under Mamsa Marma. So the reasoning and the answer goes like this. After reflecting the skin, it was observed that there was a huge bulk of muscles called calf. A point was marked with the dimension of Ardhangula, and nailing was done in the center at a distance of 12 angula from heel, which was exactly falling at the midpoint of leg. Keeping the skin intact in marked area, a vertical incision was taken and skin was reflected. Just below the skin, superficial fascia was seen at the level of marked area of locating Indrabasti Marma. The structure seen were sural nerve and short stiffness vein. The site was falling at the point which forms the junction between the muscular component of the two heads of gastrocnemius and commencement of tendinous extension, which is called as Achilles tendon. Further, the site which was marked as Indrabasti Marma contained united part of two heads of gastrocnemius and soleus, under which the posterior tibial artery and the peroneal artery, along with the tibial nerve, was located. Further, the soleus muscle had numerous venous sinuses, which is acting as a peripheral heart. The soleal vein, acting as a storage vein, is initially more prone to circulatory stasis. The huge pads of muscles to secure these vessels may be the reason why Acharyas has classified Indrabasti Marma as Mamsa Marma. The case report in support of importance of Indrabasti Marma, the importance of venous sinuses related to soleus muscle courtesy has been given there. Soleal veins have been implicated as the site of deep vein thrombosis initiation. Soleus vein drains mainly into the posterior tibial fibular and communicating veins. The discussion based on the pramana, it is said as Ardhangula pramana. In the upper limb, radial artery was the structure which was seen in the Ardhangula neurovascular structure like posterior tibial artery and peroneal artery, along with the tibial nerve was seen exactly at that particular point. Discussion on the Indrabasti Marma as Kalantara Pranahara Marma, why it has been categorized under Kalantara. Indrabasti Marma can be included under Kalantara because Rakta Dhatu Kshaya will take place leading to Marana. But it is not Saptara, the sudden death will not be there. The person can lead the life, but so that it will go for Kalantara Pranahara Marma. In the upper limb, the hemorrhage is due to injury of radial artery and anterior interosseous artery, which is under the cover of flexor group of muscles in the forearm. In the lower limb, the cause of hemorrhage is the injury of posterior tibial artery, short stiffness vein, and the soleus muscle with the soleal sinuses. Discussion of Indrabasti Marma based on cadaveric observation in the lower limb. The Marma is constituted by the Mamsa, but the Agataja Parinama give rise to vascular symptom. Hence, in this region, on the superficial aspect, there is short stiffness vein or the substance of calf muscles. There are many sinuses and perforating veins within the soleus, and under the cover of which posterior tibial artery with the vena comitatus is present. The fracture of tibia and fibula may give rise to acute compartment syndrome, in which there is obstruction of venous outflow leading to further swelling and muscle ischemia. In clinical practice, it is seen that the general surgery or deep injury patient, that is deep vein thrombosis, in this event going to manifest, and the person thrombosis, the symptoms will be edema or the area of thrombosis, involvement of shonita. And its position related to calf muscles itself inhibits the detachment of thrombi from the site of formation and its further circulation, causing pulmonary thromboembolism. Though even if loss of blood is not seen in local area, if the thrombi is successful in entering the pulmonary artery, it leads to pulmonary thromboembolism. Sign of pulmonary thromboembolism includes low blood oxygen level, rapid breathing, rapid heart rate, and sometimes a mild fever. Severe cases can lead to fainting, abnormally low blood pressure, and sudden death. Most accepted explanation in the theory of local venous hypertension, when the intraluminal venous pressure exceeds the interstitial pressure within the compartment, allowing a continuous venous flow, increasing interstitial pressure, leading to an increased intraluminal venous pressure, preventing vascular collapse. This leads to decreased gradient between the arterioles and the veins, which in turn decreases capillary blood flow within the affected compartment. This can be correlated with the Shuntakshaya and ischemic changes in the region. One of the studies says that there will be irreversible nerve and muscle damage begin after 5 to 6 hours of ischemia. More recent clinical studies revealed that muscle necrosis occur within the first 3 hours. That's why the Acharya may have given prominence for the structural entity as Mamsa, which is predominant in Indrabasti Marma. By considering the effect of injury in the calf region and its pathophysiology, it is revealed that there is a main role of blood and blood vessels in manifesting the life-threatening conditions like a deep vein thrombosis, thromboembolism, compartment syndrome, etc. Therefore, the Shishruta thought about Indrabasti Marma, which stand true for the explanation. This is a case study where you can see the fracture of tibia and fibula, and there's a crushed injury on the posterior aspect of the left leg region. In this case, there is a severe crushed injury in the calf region, posterior tibial artery, the nerve, as well as the fracture of the shaft of the tibia and fibula. Due to severe bleeding, patient went into hypovolemic shock. At this area is very vascular. Therefore, this case reveals the composition of Aghata Lakshana of Indrabasti Marma, as immediately surgical treatment is received by the patient so that the death could not occur. However, there is a permanent deformity observed. He was not able to walk properly. The conclusion goes like this. The location of Indrabasti Marma was found to lie on the vascular structure at the level of mid of forearm and mid of calf in the lower limb. The discussion related to Kalanta Pranaharatvam of Indrabasti Marma has confirmed by studies done on conditions like compartment syndrome, vascular injury leading to bleeding, thereby loss of blood further leading to edema, and ischemic changes having an impact on the muscular component of the area, leading to further necrosis of the muscle due to reduced capillary permeability and loss of function. As the neurovascular structures was placed under the cover of muscles, that is the flexor group of muscles in the upper limb and the calf muscles in the lower limb, that might be the reason why Acharyas have mentioned it as Mamsa Marma. Hence, the study of Indrabasti Marma, which is Ardhangala Pramana, Mamsa Marma situated in Jangayor Madhye and Prakoshta Madhye, is revalidated by literary and practical observation. Thank you. These are the references.
Thank you, Doctor, for this enlightening presentation on a relevant topic.
Thank you, Madam.
So next I invite Dr. Shilpa Sanjiv Patil.
Yes, ma'am.
Good evening, Doctor.
Good evening, ma'am. Good evening.
Excuse me.
Sorry, Dr. Shilpa. We will call you next, doctor. Next, I would like to invite Dr. Anagha Palak. Dr. Anagha,
Yes, sir.
please share the screen, doctor.
Is it visible?
It is on sharing, doctor. It's now visible, doctor. Please start, doctor.
Okay, good evening, everyone. This is Dr. Anagha Phatak, and my topic is high origin of profunda femoris artery and variant branching pattern of femoral artery. So this is this article on the variation that was found while dissecting a body in our college. So introduction, the normal anatomy of femoral artery is It's of artery of femoral origin and enters the femoral triangle behind the inguinal ligament at the mid-inguinal point. So in the figure, it is visible that the line in the green color is called the mid-inguinal, is the inguinal ligament, and the external iliac artery continues below the inguinal ligament as femoral artery. Mainly, it gives up to 6 branches, 3 superficial and 3 deep branches. The superficial branches are superficial epigastric artery, superficial circumflex iliac artery, superficial external pudendal artery, whereas the deep branches are deep external pudendal artery, muscular branches, and the main branch of femoral artery being the profunda femoris artery. So this is the figure depicting the normal anatomy of femoral artery and profunda femoris. Coming to the introduction and normal anatomy of profunda femoris, the profunda femoris artery, which is also called as the deep femoral artery, is a branch of femoral artery, and it takes origin 2 to 5 centimeters from the femoral artery below the inguinal ligament, and it gives rise to many branches, out of which medial circumflex femoral, lateral circumflex femoral, and 3 perforating arteries, and it terminates as the 4th perforating artery in the thigh region. Coming to the case study, during routine dissection of femoral triangle, it was observed that the profunda femoris artery was arising high up from the femoral artery, almost at the level of mid-inguinal point. So instead of arising 2 to 5 centimeters below the mid-inguinal point, it was arising at the level, almost at the level of the mid-inguinal point. The femoral sheath that encloses femoral artery and vein was very short, and some of the branches which were supposed to emerge from femoral artery were seen emerging from profunda femoris artery, and this was seen unilaterally in the left lower limb. So looking at the figures, the figure 1, which is femoral artery on the right side, it was normal in anatomy. The one painted in red is the femoral artery. So femoral artery continued down up to 4 centimeters from the inguinal ligament, and then it gave rise to profunda femoris artery. Whereas the figure 2 shows the variant branching, which is the artery gave rise to profunda femoris almost at the level of mid-inguinal point. So it was only 1 centimeters below the mid-inguinal point. Looking at the branches of femoral artery, the deep circumflex iliac artery is a branch of external iliac artery. So when we retracted the inguinal ligament, we could visualize the external iliac artery, and then this was one of the branch emerging. The inferior epigastric artery is also a branch of external iliac artery, that is the out of which it continues as femoral artery. So when we retracted the inguinal ligament, we could visualize the branches of external iliac artery. One was the inferior epigastric artery. The superficial circumflex iliac artery, one among the 3 superficial branches of femoral artery, the other being pudendal artery and epigastric artery. Those 2 were not seen emerging directly from femoral artery, but we could only visualize one superficial branch, which is superficial circumflex iliac artery. Next is the profunda femoris. As seen in the figure, the femoral artery bifurcated into profunda femoris and at almost at the level of the mid-inguinal point, and the arrow is showing the profunda femoris artery. We can also see that another branch is arising. So it looks like it's trifurcation, but the other branch is arising from the profunda femoris artery immediately as it originates from the femoral artery. So this branch is, we termed it as the common trunk because it was about an inch, and then it divided into medial and lateral branches. So the medial branch was seen passing through towards the pudendum. So we termed it as common external pudendal artery, and the lateral branch it coursed towards the neck of the femur. So it was the lateral circumflex femoral artery. This is the common external pudendal artery, which was seen passing to the pudendum, and it divided into superficial and deep external pudendal arteries. So the superficial external pudendal artery, which was supposed to be a branch of femoral artery, was arising from the profunda femoris artery. The arrow shows the lateral circumflex femoral artery, which was the lateral branch of the common trunk arising from profunda femoris, and it coursed towards its anastomosis of trochanteric and cruciate. The medial circumflex femoral artery, originally it was originating from profunda femoris, and the same anatomy can be seen here also. So among the three branches of profunda femoris, which is lateral circumflex and medial circumflex and perforating branches. We could visualize two branches from the profunda femoris artery. Further, the profunda femoris artery continued downwards to give rise to the muscular branches. And you can see the arrows depicting the muscular branches and also the perforating arteries. So the profunda femoris gave rise to perforating arteries, which from the anterior compartment of the thigh would perforate towards the posterior compartment to give vascularity to the muscles present there. And you can see the profunda femoris artery terminating as the fourth perforating artery. So in this figure, we can see on the left the femoral artery the bifurcation above into the profunda femoris, which immediately gave rise to a common trunk, and it divided into common external pudendal artery and lateral circumflex femoral artery. The femoral profunda femoris further continued downwards, giving rise to the muscular branches and perforating branches. So this is the courtesy is given, and this is an article that is published regarding the various origins of deep femoral artery, which is also the profunda femoris and its branches, the medial circumflex femoral artery and lateral circumflex femoral artery. So this study shows the position of origin of profunda femoris. And the discussion: under normal circumstances, the anatomical variations do not affect the function of the organ, but clinically they play a significant role in diagnosis and therapeutic procedures. So it may require more attention or specific arrangements. So anatomical variations can be closely linked to race, environmental adaptation, geographical region, and exposure to chemicals or radiations. Thus, identifying these variations will reflect malpractice. So the importance of such that they represent a variant of normal presentation and usually do not require therapeutic activities. However, present diagnostic dilemmas become more symptomatic under certain conditions. A discussion regarding the variation of profunda femoris. So during the procedures like arteriography, vascular reconstruction of proximal leg necessitates the precise anatomy of PFA or profunda femoris along with the femoral artery. So the knowledge of site of origin of PFA is important as it helps in avoiding iatrogenic femoral arteriovenous fistula while performing a femoral artery puncture and enables to identify the correct site of making incision. It also helps during preoperative clinical evaluation for surgical and interventional revascularization of iliofemoral and femoropopliteal segments, and in open canalization of femoral artery for cardiopulmonary bypass, and radiological interventions for AV malformation and salvage operations for traumatic limb ischemia. These are some of the situations where knowledge of variation is very important. Conclusion: the anatomical variations represent a variant of normal presentation and usually do not require therapeutic activities. So the variation of branching pattern of femoral artery is common, but high origin of PFA at the point of inguinal ligament is seen in 3% cases only. In the present study, one branch by name superficial epigastric artery was missing. So it was not seen emerging either from femoral artery or profunda femoris artery. So there is a question mark as to where it might have been emerging. So probable conclusion was inferior epigastric artery. The only superficial circumflex iliac artery was seen emerging from the femoral artery. All other branches except that were seen emerging from the profunda femoris directly or indirectly. So knowledge of such variations will be helpful in surgical interventions, iatrogenic femoral arteriovenous fistula while performing FA puncture, etc. Thank you very much.
Thank you, Dr. Anagha Patak. Next, I would like to invite Dr. Shilpa Sanjiv Patil for the paper presentation. Dr. Shilpa?
Yes, sir.
Okay, Doctor. Please share the screen, Doctor.
Sir, I'm not able to share. Can you share my PPT? Hello.
Okay, Doctor. 1 second, Doctor. So please start.
Good evening, all. I am Dr. Shilpa Sanjiv Patil, a BMS MD, PhD scholar, Ksharasutra department. Today's topic of my presentation is Ayurvedic aspect of dietary management in lifestyle disorders. Next. These are the contents of my presentation. Next. Let's start with introduction. Lifestyle means the way person live. Lifestyle disorders are also called as non-communicable diseases. The WHO, according to WHO, about 70% deaths occurs across globe due to NCDs, that is non-communicable diseases. In India, mostly in urban areas, these diseases are rising exponentially. In 70s, it is about 2%, and it went to affect more than 15% in the year of 2020. There are main four factors causing lifestyle disorders, which are unhealthy diet, physical inactivity, alcohol, tobacco, also high stress level, poor sleep, etc. Next. Aim of my study is to study the role of diet in the management of lifestyle disorders, to study the Ahar Vidhi Vidhan. Next. These are the material method. Next. WHO listed some lifestyle disorders like cardiovascular diseases, COPD, obesity, CKD, etc. Next. A lifestyle disorder management, which includes preventive and curative. The dietary regulation, which is included in both preventive and curative, because in Ayurveda, because in Ayurveda has explained the importance of Ahar. Next. Acharya Charak mentions Ahar as a pran, that is the life of healthy human being. Also, it is included in the Trayopstambha. And Acharya Kashyap has given importance to Ahar as mentioned in the Mahabheshajya. Next. Acharya Charak mentioned the dietary guidelines, which are termed as Ahar Vidhi Vidhan. Sir, next slide. It includes guidelines about how should be your meal that is prepared, or that's quantity or environmental condition, etc. Let's see one by one. Next slide. Ushnam Ashniyat. Ushnam Ashniyat means eat hot food. Next slide. It increases the digestive power and leads to early digestion or digest food in proper time. It does Vatanuloman. Due to hot food, there is a secretion of saliva occurs more and helps in the digestion, also kills bacteria. Sir, next slide. So, next. Snigdham Ashniyat means diet should include fat. Snigdha means not only the growth or tail, but it also includes the food articles which are having snigdhaguna. For example, godhum and shali. Snigdhagun, it causes the pak of malas, and it breaks the bond between the malas and causes responsible for easy excretion of mala through guda. It also responsible for absorption of the fat which is present in food, responsible for absorption of vitamin, that is fat soluble vitamins A, D, E, K, and HDL, which is a good cholesterol, which decreases the risk of heart diseases. Next slide. Matra Vatashniat means the balanced diet. Matra means one should take food according to their Agni and Bal. Also, Acharya Charak stated that the Gurunam Ardha Sohityam and Laghunam Na Ati Sohityam. Next. Jirne Ashniyat means take food after the digestion of previous meal. The evidence of digestion of previous meal are Udgar Shuddhi Utsaha, Vegotsarga Yathochita, Laghutak Shut Pipasa, Jirnaharasya Lakshana. If we take food earlier, then previously undigested aharas get mixed with newly formed aharas and results into the amotpatti, which vitiates the tridoshas and causes the disease. Next. Virya Viruddham means virya is a quality of a drug by which the action takes place. The diet having property dissimilar to body elements which are not acceptable with systems are called as Viruddhahar. It is essential to take Virya Aviruddhahar to avoid problems arising due to Viruddha Viryahar. One should not eat hot and cold diet together. It causes, it results into toxin formation. Nowadays, people love to or prefer to eat ice cream after taking hot food, which is an best example of Virya Viruddhahar. Next. Next slide. Ishta Deshe, Ishta Sarvopkaranam. The place where should be where food should be prepared or equipments used for preparation must be hygienic, clean, peaceful, and do not cook food with disturbing emotions like stress, anxiety, anger. And because there is a connection between the gut and brain, which affects the gut health, that is the gut-brain axis. Next slide. Nati dhrutam means do not eat too fast due to because it goes into wrong pathway, that is into respiratory tract, and it causes the infection and choking like problems. Next slide. Nati vilambita, do not eat too slowly. Due to slow eating, one can eat more than requirement, and also food becomes cold, which disturbs the digestion. Next. Ajalpa ahasan tanmana bhunjit. Eat food food without talking or laughing, and with mindful, which is a mindful eating, because while eating or talking, it goes into another pathway. It has same effect as explained in atidrutam condition. Also, take food with peaceful mind, because the digestion is a psychosomatic process. Next. Discussion. The faulty dietary habits is responsible for health disorder in present era. With the help of Ahar Vidhi Vidhan, we can reduce the Sampraptikatak of diseases. Ayurveda recommends a variety of practical techniques for keeping our digestive fire strong. Incorporating these practices into daily life can strengthen the Agni, and in turn facilitates the metabolism of food and minimize the uncomfortable GI symptoms. Ultimately, it reduces the risk of lifestyle disorders. The dietary guidelines mentioned in Ayurveda, that is Ahar Vidhi Vidhan, if it is difficult to follow in present era, then think about the solutions. For example, we should take hot food on working place. There is no, if there is no facilities there, then wrap your tiffin in aluminum foil or get into a thermos. Conclusion. The intake of ahar in appropriate quantity and also quality food is essential for good health of a person. To receive the total benefits of ahar, it is necessary to have the knowledge about ahar vidhi vidhan. Along with this, minute lifestyle changes like exercises, meditation can protect from various diseases. Conclusion is that scientific guidelines given by acharyas will definitely avoid lifestyle disorders. Next. This is previous work done. Next. Next. These are the references. Next. Thank you.
Thank you, doctor. Now I invite Dr. Gururaj Patil. I invite Dr.
Gururaj Patil. Dr. Gururaj Patil, please unmute, doctor. Hello, Dr. Gururaj Patil, can you hear me? Hello, Dr. Gururaj Patil, can you hear me? Okay, next I invite Dr. Vinod Nivrutti Powar for the presentation. Dr. Vinod.
Yes, sir. I'm here. Is I am audible?
Audible, doctor. Please share the screen, doctor.
Okay, sir. Sir, please help me to share slides from your side.
Okay, doctor. 1 second, doctor. Vinod Powar, please start the session, doctor.
Okay, sir. My topic, my name is Dr. Vinod Powar. My topic's name is Vajikarana, its utility in health and disease condition. Sir, can I proceed?
Doctor.
Yes.
Sir, please continue, doctor. Is this screen is visible, doctor?
Yet not.
Hello, doctor. Can you hear me?
Yes, sir.
Sir, please continue, doctor.
Yes. Now screen is visible. Good evening, all of you. To this topic, I am doing PG in social department from Codal College. My topic is Vajikarana, its utility in health in disease condition. Vajikarana, long-lasting since the descent of Ayurveda. It makes essential purification of the body, cleansing through Panchakarma Shodhana. These are some references. Next, definition of Vajikarana. The therapy which renders a person potent enough to produce healthy offspring, provides instantaneous sexual arousal to the extent that one can perform uninterrupted sexual act, nourishes the tissue so that even in old age, semen is not diminished, brings about happiness, longevity, beauty, strength, and nourishment is known as Vajikarana. Next, Vajikarana therapy includes Virya Shodhanavati, Makarodojavati, Siddha Makarodoj कामचंदादि रस वसंत पुष्पांतिक रस अश्वगंधादि चूर्ण कुंचन पाक उसली पाक. Next, Vajikarana specific remedies for male in infertility and impotency as well as in female infertility. Second use is Saundarya Sadhana, beauty and cosmetic treatment for men and women, including skin, hair, eyes, posture, body odor, and general appearance. Next, a branch of Ayurveda focus on aphrodisiac sexual therapy and reproductive health. Kripalu. Next, Vajikarana formulations. There are hundreds of different formulations which are used for Vajikarana. Some of these formulations are mentioned below, which are used commonly. Vrihini Kutika. Sir, one sec. Please show me. Yes. Vrihini Kutika. Vajikaranam Grihitam. Pushya Kutika. Utpatkari षष्ठी काढ़ाकुटिका, मेध्यादि योग. Next, seasonal influences in Vajikarana. ग्रीष्म शीतल विहार, वर्षा मेघा जल निदानम, शरत रात्रि मूनलाइट, हेमंत स्त्री वारांगना कामिनी शिशिर कामिनिका. Next, in Sanskrit, Vaji means horse, the symbol of sexual potency and performance. Thus, Vajikarana means producing a horse vigor, particularly the animal's great capacity for sexual activity in the individual. Literally, Vajikarana is not exactly aphrodisiac, but the current contextual meaning is same. Next, who should not consume Vajikarana preparations? As per Ayurveda, it is recommended that the person below 70 years of age and more than 70 not consume Vajikarana preparations. These preparations have to be consumed by Jitendriya Purush or man who has control on his sense and desires. If Vajikarana preparations are consumed by a Jitendriya Purush or man who has lost control over his sense and desire, he may prove harmful to the society. Thank you.
Thank you, Doctor. Now I invite Dr. Aneesh G. I invite Dr. Aneesh. Dr. Aneesh.
Okay, next I invite Dr. Minal Savale for the poster presentation. Dr. Minal Savale.
Hello.
Doctor.
Yes, sir. Can you hear me?
Please share. Yes, doctor. Please share the screen, doctor.
So I've sent my poster. So do you have that?
Yeah, doctor.
Hello.
1 second, doctor.
Yes, sir.
Doctor, please start the session, doctor.
So I cannot see my poster here. Yes. So my name is Dr. Minal Savale. I'm a second year PG student of Rog Nidan at Sumati Bhaisha Ayurvedic College, Hadapsar. And my topic is a review of Rakta Moksha and management of Shul. So it was being a poster, I couldn't describe it much. I just concised it, but I'm going to explain it as I go along. According to, first going to the importance of Rakta, according to Ashtang Hruday, we see that Prinanam Jivanam Depa Sneha Dharnisha Purna Garbha Utpadasya Dhatunam Shreshta Karma Ityadi Dhyate. So the karma of Rakta is Prinanam, as we know, and along with other dhatus, it also does the work of Ojavardhan, also mentioned as one of the Pranayatan by Charak and Ashtang Sangraha in Dasha Pranayatan. So Rakta is said to be the Jivan and one of the Pranayatan. Next, we see that in Charak Sutra Vidhi Shonit Adhyay, there's a shlok. Shito Ushna Snigdha Rukshadu Rupakrantasya Yegadaha Samyak Sadhyana Siddhyati Rakta Jastanama Vibhayata. When we see in treatments, in Vyadis, where we cannot see outcome by any kind of Shita Ushna Snigdha Ruksha treatment, we see the Anubandha of Rakta. And because of this Anubandha of Rakta, we see Anupashaya. So for treatment, we have to think of Rakta treatment, which is the Rakta Mokshan Chikitsa. Then we see Kuryata Shonita Rogeshu, Rakta Pitta Haritriyam, Vireka Vamanam Upasam, Stravanam Shonitasya cha. All the Raktaj rog should be treated as Rakta Pitta Vyadhi Chikitsa, which is Virechan, Upvas, and Rakta Mokshan should be followed. Now moving towards Shul, according to Sutra Nidan, Vata Drute Nasti Rujam, Na Paka Pitta Drute Nasti Kafacha Puyaha. Shul is created by Vata in three ways. Upastamba, that is Marga Rojanya, Nirupastamba, that is Dhatuksha and Aghatach, which is a Sthanik Vat Dushti. In doshas like Kapha Pitta, then others Am, Mal, Vat, there's Vimarga Gaman that causes this Upastamba with creating that creates Shul. In case of Aghatash, Vayu gets aggravated in one particular location and it can be cured by Rakta Mokshan, that means clearing the Upastamba. In Upastamba, we follow the Vatanaluman Chikitsa. As Basti is considered as the half treatment of Vayu, same way, Siravat is considered as the Ardha Chikitsa of Rakta, according to Sushruta Shaareera. Then aims and objectives are the review of Rakta Mokshan as management in Shul indicating Vyadhis. The material methods of are Rakta Mokshan by Shastra Pranidan or Anushastra Visarjan. In Shastra Pranidan, we see Prachan Karma and Sira Ved. In Anushastra Visarjan, we have Jaloka for typical Pitta Pradhan Vyadhi, Alabu for Kapha Pradhan Vyadhi, and Shrunga for Vatash Pradhan Vyadhis. So now moving towards the Vyadhis by one. So if you could zoom a little on the first chart. The first Vyadhi is Granthi. Granthi being Kapha dominant Vyadhi in the first place. The symptoms are still leaning towards Vat, which shows us Vedana Dikya. Then because of Pitta, we see Dhumavat Vedna, and Kapha we see Alpa Vedna. Having Adhikya and Vedna, so we have to go towards the treatment of Vat, which is Sira Ved at the greater toe. And in case of Pitta, we can see Jaloka Ucharan for the same. So could you please zoom in towards the first chart? Hello. Moving forward, Gulma, which is the Vyadhi Gulma. Vayu provokes Pitta and Kapha and obstructs the channel of circulation, causing moving type of pain. In this, we can see the Sanchari Vedna, which are Sadaha and Alpa. The Raksha Mokshan stand at this will be the stand of the Gulma. And when there is no indication of what kind of Rakta Mokshan, it should be particularly Siravad. In Visarpa Vyadhi, the doshas are Vat, Pitta and Kapha. The kind of shul we see is Tivra Vedana, Daha, Kandu and Kot. The mostly stand for Rakta Mokshan should be at the site of the pain. In Galaganda Vyadhi, the doshas are Vat and Kapha. The shul is Alparuja, increase as per the size. As the size increases, the pain increases. The Rakta Mokshan stand is local Siravat and veins below the tongue. In Vyadhi like Gandamala, the doshas are Vat, Kapha by Charak and Tridosh by Vagbat. The shul is Alpa Vedana, and when there is Pak, there's Vedana Adhikya. Rakta Mokshan stand is Indrabasti Marma. In Arbuddha Vyadhi, the doshas are Vat, Pitta and Kapha. Shul is Vedana Alpa. When there's inclusion of Rakta, we see Vedana Adhikya. First there's Vedana Alpa and then Vedana Adhikya. Rakta Mokshan stand at, it will be at the site, and when there's inclusion of Vata, it should be Shrunga. The Pitta, the Rakta Mokshan type should be of Jaloka. In Kapha, it's Alabu, and when there's Tridosh, Prachan Karma should be done. And in Pashan Garda, when there is a Pashan Garda, painful, constant swelling at the temporomandibular joint, the doshas of Vat and Kapha. The shul is Tivra Vedana and Gaurava. Rakta Mokshan stan should be below and above the 4 anguli of knee joint. Next Vyadhi, moving towards the Shira Rog, Anantavatam. The doshas are Vat, Pitta and Kapha. Shul is Ati Tivra Vedana, and Rakta Mokshan stan should be the Apanga Sira Ved. Apanga Pradeshi Sira Ved. The Shankaka, the extreme pain at the temples. Dosha is Vata and Rakta. Shul is at the Shanka Pradeshi, which is kind of Ati Tivra Vedana. The Rakta Mokshan stan is also again the Apanga Pradeshi Sira Ved. Next Vyadhi is Vata Rakta. Dosh are Vat, Pitta and Kapha. The shul is Tivra Shul, Daha and Kandu. Rakta Mokshan stan, Rakta Mokshan should be Sira Ved by Jaloka and Shunga or Alabu. Next Vyadhi is Raktagata Vat. The dosh is particularly Rakta. The Shul is Tivra Shul. Rakta Moksha Stan is Siravet and Shrunga. In Sandhigat Vat, the dosh is Vata. The kind of Shul is Tivra Vedana and along with Daha. And there should be local Rakta Moksha, which means again Siravet. So my conclusion towards this is we can see that Rakta Mokshan is not only clearing the avarod in these Vyadhis, but also cleansing the Vat along with the anxious substance. It could be either Pitta, Kaph, Mal, or Avrutattva atva Dhatu without increasing Pitta or Kaph at the local place. It causes Samprapti Bhanga and Marga Avrod Janya Vyadhis that causes reduction in the shul that we are seeing. It leads us from Anupashaya that we were having first by going for Snigdha Ushna, Snigdha Ruksha, Upakram, which were not giving us any kind of Upashaya. Rakta Mokshan, in particular these diseases, by treating Rakta, we can see Upashaya of these Vyadhis. So these are my references, and my name is Dr. Minal Savale, PG student, SSAM Hadapsa. Thank you, sir.
Thank you, doctor. Now I invite Dr. Gururaj Patil. Dr. Gururaj, please unmute and respond.
Good evening, ma'am.
Good evening, doctor.
Am I audible, ma'am?
Yes, doctor.
Ma'am, please share the screen for me.
Doctor, please
Good evening,
start
everyone.
the session, doctor.
Okay. Myself, Dr. Gururaj Patil, a PG scholar of Tantra Department, Engineering College, Rina. So my topic is the role of Ksharasutra in the management of Scrotal sinus, a case study. Next. So in Ayurveda introduction, in Ayurveda it is mentioned that a clinical condition requires a surgical intervention for better cure. Charaka, mainly a chichitis, also stated that a disease like Gulma, Arsha, Bagandhara, many Ashmari require a surgical intervention. Sushruta discussed in the detail about various Shastra Karma along with Anushastra Karma, which include Agni Karma, Jaloka Charana, Kshara Karma. A Kshara is considered as one among the important parasurgical procedure as it can produce excision, incision, scraping, and specify all three doshas. Kshara application in the form of Ksharasutra in anorectal diseases as well as become a more popular and is easy approach. Low rate of recurrence. Ksharasutra induces both mechanical and chemical as well as healing. Ksharasutra induces both mechanical and chemical healing. Direct reference of Ksharasutra is found in Sushruta Samhita. In Nadi Runa Chikitsa, Chaturtha has also referred a medicated thread coated with Snohi and Haridra powder in treatment of Arsha and Bagandra, but the modified Ksharasutra available now established by the Department of Shalla Tantra at Banaras Hindu University. The standard Ksharasutra is prepared out of 11 coatings of Snohi Shira, then 7 coatings of Snohi and Avamarga Kshara, and then 3 coatings of Snohi Shira and Haridra Churna. This Kshara is used in the treatment of fistula in due to its cutting and it controls the infection. In this case study, a scrotal abscess with a tract measuring about 6 cm was treated by Ksharasutra, which was cured, and no further complaints were found in the patient during follow-up period. The shofa of prolonged Pakwa Avastha, when ignored, produces a large amount of pus which percolates into the deepest tissues, ending up in complications like sinus, fistula, forious gangrene, especially forious gangrene, septicemia. Eventually, a surgeon has to decide and go for orchidectomy for patient's survival. A nadi means a tract, vruna means an ulcer. So, an ulcer having a tract is called nadi vruna. Kshara destroys the vitiated tissues and make them fall off. It is the most important among Shastras and Anushastra because it does functions like the above mentioned. Next, sir. A case report having a patient of XYZ 40 years, male gender, and it was admitted on 24 2022 and recovered in 18/5/22. Patient complains of first discharge with mild pain at the right side and left scrotal region since 2 months. Patient was apparently normal before 4 months. Then he had developed a boil with intermittent discharge of anterior portion of the scrotal since last 2 months. He also complained of mild pain and discomfort while sitting and continuous first discharge since. Then he was referred a contemporary surgeon where he got debridement and dressing was done. Eventually not relieved, planned to go for orchidectomy. So the patient came to our OPD of Medical College, Bidar. So these are all the history. So please next sir. Local During local examination in patient in supine position, observed that patient has very region, small opening in the right side of the left region of seropurulent discharge. Through that opening, the tenderness on touch with indurations was felt around the external opening. The probing was done from the anterior opening to access the internal tract, but opening was fibrosed. About 6 centimeter it was found during probing. An opening was made at inferior uh, part of scrotum. After complete examination, the diagnosis was confirmed as a scrotal sinus in the patient. Scrotal skin was normal with dermatitis and swelling is locally and hardness was felt. So preoperative procedure is nothing but a local part preparation. Shaving was done. The patient at night before operation, bowel was passed. The patient was taken recovery room, injection TT and xylocaine. Xylocaine 2% was given for sensitivity test. Operative procedure is the patient was taken in a supine position for operation. The painting and draping, local anesthesia of 2% xylocaine was interpreted nearby opening and downwards below the sinus. Reassurance of extension of tract was done. Probing. The probe was removed through a manually via making an opening after feeding Ksharasutra and Ksharasutra ligated appropriately. Complete hemostasis achieved and bandaging, circular bandaging was done. So post-operative care is analgesics with Ayurvedic medicines with 6 bath. Patient was admitted to the hospital for 7 days. Trifla Guguru Gandha Krisana, patient was advised to take Khichdi and Dalia. He was also advised to resume his normal day-to-day activities. So follow-up is patient was discharged from hospital after first Ksharasutra change and then after changing Ksharasutra every 7th day during cutting or 6 bath. It's the Apple Taylor local application. Patient was allowed to do his routine work. After 6 sitting, the tract was totally cut and healing was achieved simultaneously. So the discussion is adopted surgical techniques in contemporary science for the management of scrotal fistula is excision and secondary intentions, excision and primary closure reconstructive flaps. In this case, the report has external openings were far away from the medial raphe involving both scrotal region and many ramifications were present. Contemporary doctors advised for orchidectomy, so patient was planned for Ksharasutra. Its modalities like Ksharavati and Ksharasutra was adopted. Ksharasutra does the both cutting and healing. It was used for threading between the main sinus and an external opening was made manually. Approximately 6 centimeters Ksharavati was kept on the other side. So this is the changes. These are the list of references. Thank you.
Thank you, doctor. So next I invite Dr. Krishnaja K T.
Am I audible?
Hello, doctor.
Hello, am I audible?
Yes, doctor, you're audible.
Yeah.
Dr. Krishnaja?
Yeah.
Doctor, please share the screen, doctor.
Okay. Oh, can you please share me my screen?
Doctor, one second. Please start the session, doctor.
Okay. Good evening, all. Welcome to the presentation. Topic of my presentation is Origin of Visha as per Samhithas. I am Krishnaja K T, first year PG scholar, Department of Agriculture, PPSC Ayurvedic College, Kotak. Next, sir. Next. Coming to the Visha Nivrutti, the term Visha is originated from the Dani root Visha. It means to encompass, to get fully pervaded, to get occupied. Thus, the one which pervades the whole body immediately after ingestion is called as Visha. Next, sir. Coming to the definition, Deham Pravishya Yadravyam Doshayitva Rasadiga Swasti Pranaharam Sasya Tada Dravyam Visham Uchide. This is a reference from Yoga Ratnagara, a substance which disturbs the functions of Rasadidadi after entering into the body and separates prana is called as Visha. Yes, sir. In Madhav Nidana, it explained that Vishada Janatva Visham. In Susruta Samhita Kalpasthana, Vishada Janatva Visham Ityabhidile. In Charita Samhita, Jagat Vishanam Tam Drishtva, Tenaso Vishatapnidam. That is, Visha is that which causes Visha, that is, gloom or soreness. Next. Coming to the synonyms of Visha, in Tisataringini and Amarakosha, Visha, Shweda and Garala can be seen. In Rajamugandi, Visha, Shweda, Garala, Kalakura, etc. can be seen. Next, sir. So, Abhidhantra is a significant branch among Ashtangas of Ayurveda. Coming to the Nirupti and definition of Abhidhantra, Nasti Gado Yasya, that means free of disease or illness. Nasti Gado Yasma, that is medicine, health or knowledge of restoring Visha. Abhidhantra means a science that deals with antidotes or agata or medicine that combat toxins. Coming to the definition, in Susruta Samhita, definition of Agadhatandra can be seen as Agadhatandra Nama, Sarpa Keda Luda Moshagadi Dashta, Visha Janjanartham, Vigda Visha Samyoga Upasanartham. Next, in Harita Samhita, Sarpa Rustika Ludana, Vishoka Shavanaya Kriya, Sakriya Visha Tandram Nama Gauta Manishivi. Next. Terms for Agadhatandra by different Acharyas. In Charaka Samhita, Vishagara Vayodika Prasanna is used and Susruta used Agadhatandra. Vruddha and Legu Vagbada used the term Vansha Chikitsa, and in Harita we can see Vishatandra. Next. Coming to the mythological origin of Visha. Next. Next. In Charaka Samhita, while the ocean was being churned by the gods and demons for obtaining ambrosia, even prior to the production of ambrosia, a ferocious-looking person who was resplendent with aura and who had both fangs, stony hair, and fiery eyes emerged. The bird became desperate at his sight, because of which he was called Visha or poison. Lord Brahma deposited this poison in Jangama and Stavara things. Next slide. Visha is Ambusamba because its origin is from seawater and it is Pavagogma. Visha characters are similar to Agni. It is of two types, Stavara and Jangama, and its Ambudasa is due to origin of Visha and Amrita same. So if a poison administered in therapeutic doses, it acts as Amrit. Next. Natural aggravation and elevation of visha is mentioned in Charaka. Next. Because poison originates from water and becomes sticky like jaggery when it comes into contact with water and spreads during rainy season. However, the star Agastya at the end of rainy season counteracts the effects of this poison. Therefore, the effects of poison become milder after the rains are over. Next. Next, in Susruta Samhita, we can see third chapter Jangama Visha Vijnanina, Vishotpati is mentioned. When Lord Brahma, by creating living beings, a demon by name Kaidaka, overcome by anger, created hindrance to the world. Then from the mouth of Brahma, his anger came out in physical form and burned the howling and powerful demon. This anger greatly increased, caused fear and grief among the gods by his very side. Hence, he came to be called Visha. Then Brahma, after creating the rest of the living beings, deposited with visha in all things of the world, Stavara and Chara. Next. Next. In Ashtanga Sangraha, long ago when Suras and Asuras swam the ocean for obtaining metal, there was a person appearing like anger personified, black in color with fire-like eyes, shining hair standing on the head, terrifying teeth, frightful bows and countenance. Since both gods and demons became Vishanna by merely looking at him, he came to be known as Visha. Next. Bent on destroying all living things soon after his birth, this Visha was blessed with immortality by Lord Brahma and made to reside in plants to be made use of for special purposes. Next. Next. In Ashtanga Hridaya also, the same origin as Ashtanga Sangraha. Next. 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 Next, sir. So, Stavara Visha is Kalavuda, Indravalsa, Shringi, Halahala, etc. And Jangama Visha is Sarpa Ludadi and Kritrima Visha is Gara. Coming to the Visha Adhishtana, Stavara Visha Adhishtana is mentioned in Susruta Samhita Kalpasthana. It is of 10 Mula, Patra, Phala, Pushpa, Top, Shira, Sara, Nityasa, Dhanava, Kanda. In Ashtanga Hridaya, Kanda is Adhishtana and Charaka mentioned Mula only. Next. Coming to the Jangava Visha Adhishtana, 16 are mentioned in Susruta. Drishti Nishwasa Damshta, Nagamutra Purisha, Shukra Lala Artava Mukha Samdamsha, Visarvida, Tunda Asti, Pitta, Shudhan, Shava. Next. Classification of Visha in Samhita. In Charaka and Susruta Samhita, we can see Stavara, Jangama and Samhita. And in Vagbada classified it as Akritima and Kritrima. Next. In Bhava Prakasha, Akritrima and Kritrima are the classification. In Desa Tarangini, Stavara Visha includes Mahavisha and Upavisha and also in Jangama classification. We can see the references in Samhita, in Charaka Samhita, Chikitsasthana, Susruta Samhita, Kalpasthana, and references in Kaudilya, Arthashastra, Samhita. Coming to the conclusion, Susruta, at the time of creation by Lord Brahma, Kaidavasura made obstruction, so Brahma got angry and produced a dreadful demon to create Vishaka. In Charaka and Vagbada, we can see churning of milk ocean, a Visha Purusha originated. So these are the originates of Visha in Samhita. These are the references. Thank you.
Thank you, Doctor. Now I invite Dr. Anand Dinakar Kulkarni.
Yes, madam.
Good
I'm
evening,
sharing
Doctor.
my. Good evening. Can you share my PPT?
Sure, Doctor.
Doctor, please start the session, Doctor.
Yes, thank you.
Today's my topic is different modern Agnikarma modalities in proctology. Myself, Dr. Anand Kulkarni, MS PG scholar from Sri Shiva Yogeshwar Rural Ayurvedic Medical College, Inchal. Next, please. Next slide. Agnikarma modalities in proctology. Number one is electrocautery. Number second is IRC, infrared coagulation. Number third is radio frequency, and fourth one is laser. Next, please. In electrocautery, there are two types, monopolar and bipolar. In monopolar, as the surface area of the contact of the active electrode is small, concentrated, powerful current produce heat at operative site. It is easy to use for tissue dissection, both cutting and coagulation, greater tissue penetration. Area of coagulation is more than bipolar. In bipolar, to active electrodes as limbs of forceps, current flows between them and tissue hold between limbs, decrease thermal injury to surrounding tissue, and works well in saline. Disadvantage of bipolar: more skill and time is required. Coagulation only, no dissection. Tissue effect of electric cautery. For cutting, coagulation, and fulguration, that is non-contact procedure. Number second is IRC, infrared coagulation. It is generally used in first and second degree internal hemorrhoids, generates coagulation heat energy by infrared irradiation. The heat energy provided by the infrared irradiations causes rapid heating of the tissues in contact with the crystal, and this heating results in coagulation. Effective device for coagulation oozing surfaces. Previous, please. Previous. Has the advantages of not requiring electrical current to pass through the patient. Next. Next slide, please. Third is radio frequency. The frequency generally 4 megahertz generally used. Electrodes need not to be sharpened by blade and can be easily self-sterilized. Excellent cosmetic results causes minimal scar tissue, quick and faster healing and recovery, decreased post-operative pain, minimal smoke production and simultaneous cutting and coagulation. Hits tissue below 100 degrees Celsius. So scar is faster healing in scar is observed. Next, please. Fourth is laser. What is laser? Laser is light amplification by stimulated emission of radiation. Light of the laser is transformed into the heat for soft tissue cutting, ablation and vaporization, hemostasis and coagulation. Ablation means removal, especially by cutting with a laser or electrocautery. Vaporization to turn or cause something to turn from solid to liquid state into gas. Coagulation, the process by which blood changes into solid state to form a solid seal. Next, please. Laser in surgery. Types of laser and their uses. There are 4 types of lasers. Carbon dioxide laser, which is used in ENT, maxillofacial and plastic surgery. Argon laser, used in ophthalmology and dermatology. ND-YAG laser, used in gastrointestinal and urologic pathology, in the treatment of benign tumors and for reduction of malignant tumors. And diode laser, which is used in proctology. Next. Advantages of laser in surgery. It gives bloodless surface. It is precise, better visualization, minimal post-operative edema, and painless. Laser in proctology. There are 4 indications for laser. It is used in hemorrhoids. It can be used in fistula in ano. It can be used in fissure in ano, and can be used in pilonidal sinus. Types of laser fibers. Fibers for hemorrhoids. Special conical glass tip, sharp tip for hemorrhoid puncture. First type is conical. Second is fistula and sinus probe. Special corona 360-degree radial fiber is used, and blunt tip for safe insertion. And third one is bare fiber for fissure in ano. These fibers emit a V-shaped energy, cause a little more pain post-operatively. Next. Wavelength matters in laser. 1470 nm versus 980 nm. 980 nm, 15 watt high absorption in pigment, fastest cutting with coagulation. In 1470 nanometer, 15 watt high absorption in water for cutting, coagulation and ablation. Laser ablation using a 1470 laser resulted in less post-operative pain, better VCSS score, that is venous clinical severity score, in the first month than treatment with a 980 nm laser. Next. Thank you.
Thank you, doctor, for this informative presentation. So next I invite Dr. Ashwini.
Yes, ma'am. Good evening, everyone.
Good evening, doctor. Doctor, please share the screen.
Ma'am, can you share my PPT?
1 second, doctor.
One minute, doctor, I'll share for you.
Okay, sir.
Doctor, please start the session, doctor.
Yes, sir. Good evening, myself Dr. Ashwini Hinganikar. I'm a scholar from Shalatantra Department from Government Ayurvedic College Hospital, Nagpur. Today I'm presenting on a topic of management of Bhagandir, that is fistula in ano by integrated approach, a case report. Introduction. As we know, Bhagandir is a disease in which Bhaga, Guda and Basti region becomes vidarit, that is, it gets torn totally. In Apakva it is given by Charak, that in Apakva it is called as a Pidaka. Meanwhile, in Pakva we will call it as a Bhagandir. Bhagandar can be correlated with fistula according to the modern science. Fistula is defined as a chronic granulating tubular tract of a fibrous tissue with two openings communicating between two different epithelium. Management of a fistula in ano is a challenge due to its high recurrence rate. Ksharasutra therapy is a parasurgical procedure mentioned and described by Acharya Shushruta for cure of a fistula in ano and other anorectal diseases. In this case, 43 years old male patient was managed by partial fistulectomy and Ksharasutra insertion in a remaining tract. Next, sir. Here case history. A patient was aged of 48 years. He was a male and his occupation was a manager. Diet he was a mixed on a diet and complaining of boil at perianal region and pus discharge through that perianal region boil since 1 month. Next, sir. Present history. The 43-year male patient came to our OPD that he was complaining of having boil at perianal region since 1 month. Thus, he came for further treatment and management to our OPD. As we taken the past history of the patient, he was having no any history regarding to the HT and DM, hypothyroidism, hyperthyroidism, and no history of any past surgical history, and he was not having any drug history also. And addiction, there was no any addiction. Next, sir.
On examining the patient locally, we saw that there was an external opening seen at 12 o'clock position, approximately 6 to 7 centimeter away from anal verge, at the root of a scrotum. Active pulse discharge was present. An indurated tract was filled towards the anal verge at 12 o'clock position radially. Mild tenderness was present, and other sign of inflammation was also present. On a digital rectal examination, there was no spasm. Tenderness was present, and rectal mucosa was soft, and dimpling was felt at a 12 o'clock position on examining per rectally. Next, sir. Then we go for all the laboratory investigation, those we do for operative procedures. So all those were the investigation done at our hospital's laboratory, HB, TLC, and ESA, all was as shown in this table and also in a picture. Chest X-ray was also done for the minimum of the spinal anesthesia. Next, sir. Here the probing was done before taking the patient for the post-operative operative treatment. Under all aseptic precaution, anal verge and its periphery was cleaned with betadine, and LOX 2% jelly was lubricated on the probe, and it was inserted through the 12 o'clock opening as shown in the figure here. That 12 o'clock opening was seen at the root of the scrotum, and the probe comes out through the internal opening that was also present at the 12 o'clock position. And probes come out completely out through the anal canal. Next, sir. Here the MRI fistulogram was done of the patient. Then we saw that there was the thin fibrous fistulous tract of around 6 to 7 centimeter length is seen in left anterior perianal region. The tract shows an external opening near the root of a scrotum on the left side. The tract is seen extending posteriorly towards the anal canal and shows the intersphincteric course. The tract is seen communicating with the anal canal at a 12 o'clock position. The internal opening is seen approximately 5 to 6 centimeter from the anal verge. No any branches were seen as shown in the second figure, that we can see that there was a linear tract we can see here. The intersphincteric tract was developed from a 12 o'clock position at the root of a scrotum to the 12 o'clock position to the internal opening of the anal canal. Next, sir. So going for the operative procedure, the pre-operatively we have done all the procedure that patient's written consent was taken, and NBM was patient was put on a NBM. Then part preparation was done, prophylaxis enema was given, injection TT intramuscular was given, and xylocaine sensitivity was done. Next, sir. In an operative procedure, patient was given a lithotripsy position, and after achieving the adequate level of spinal anesthesia, clinic painting of the operative patient part was done. Syringing with a betadine and H2 was done through the external opening one, which was present at a 12 o'clock position at the root of the scrotum, and it comes out through the internal opening, which was present at a 12 o'clock position. Probe inserted through the internal opening by lubricating with LOX 2% jelly. It comes through 12 o'clock position internally. Track approximately 4 to 5 centimeter was lay open with the help of a cautery, and a remaining track was approximately 2.5 centimeter. Barber thread insertion was done in the remaining part. So the complete hemostasis was done, and the wound was packed with the betadine gauze, and T-bandage was applied. Next, sir. Here we can see in the first figure that one which I have already discussed above, that here in first figure we can see the betadine and H2A2 syringing was done. Here we can see a 12 o'clock opening at a root of a scrotum, and betadine and H2A2 coming out through the 12 o'clock position through the anal verge. Then in the next figure we can see that the partial fistulotomy was done with the help of a cautery. In a third we can see that the probe has been inserted through the tract, and the partial fistulotomy about 4.5 centimeter along the tract was done. Next, sir. In the last second, we can see that the remaining tract one, which was about 2.5 centimeter, was left over, and in this tract the barber thread insertion, initially actually we do the barber thread insertion, then after 5 days we change it with the Ksharasutra. So the procedure was done in this manner. Next, sir. In a post-operative management, the patient was kept NBM for till the next order, and no pillow below head and head low position was advised. BP charting and temperature, pulse rate, and everything was monitored. Sitz bath was given with Haridra. Antibiotics and anti-inflammatory drugs were prescribed. Gandharv 5 gram given with lukewarm water, and Ksharasutra was changed on every fifth day. Length of a track as well as the granulation of the operated wound was noted till the healing of fistulous tract. Next, sir. Results. On fifth day, wound was healthy. Mild pus discharge was present. Figure 7 here we can see. On the next, I will tell you in the next slide that in a figure 7 we can see the granulation of a post-operated wound on a 10th day with the second setting of Ksharasutra. Here the healing healthy granulation was noted and cutting of a track was noted with a rate of 1 centimeter in every setting. Dressing of a lay open track was done with a Jatyadi tel, which helped to heal the wound rapidly. On post-operative 6th week, wound was healthy, clean, and healing was promoted with a healthy granulation tissue as shown in figure 8. Figure 9 shows the complete healing of a fistulous tract and remaining 0.5 centimeter of a track with Ksharasutra along the length of a track. Next slide, sir. So here we can see in a figure 7 that the healing of the post-operative wound was done with, and the dressing was done with the Jatyadi tel, and the remaining track was ligated with the Ksharasutra. Here we can see that the almost of the track about 3.5 centimeter to 4 centimeter of the track was healed, and the remaining track was inserted with the Ksharasutra. And here we can see that this is the recent picture of a taken about 15 days ago, that about only 0.5 centimeter of the length of the track is remaining. So the Ksharasutra thread we can see also here, it can get off right or cut within might be 2 or 3 weeks. Next up. So discussion here, management of fistula with only surgical intervention is a challenge. So we applied integrated technique in this case to have a high success rate and less recurrence rate. Partial fistulectomy helps to drain out the pus collection and heals the fibrous fistulous tract by means of a Vrana open property of Jatyadi tel. Due to Vrana open Shodhana and Shothar property of a Jatyadi tel, granulation, epithelialization, and the contraction of the wound occur. Alkaline nature of a Ksharasutra cauterizes the dead tissue and facilitates the cutting as well as healing. The turmeric powder in a Ksharasutra preparation and in its sitz bath helps for healing of wound. Next. Conclusion. This case demonstrated that early healing without any anal continence by the partial fistulectomy with Ksharasutra application is the management of a Bhagandar. Healing of a post-operated wound was enhanced due to the Ropan Shodhan and Shothar property of Jatyadi tel. Ksharasutra cuts the remaining track by means of its property of a Sharana Guna. Hence, partial fistulectomy is said to be safe and best option observed in this case. Thank you.
Thank you, doctor. So it's an official end of Nagara. So before winding up, let me take a few minutes. First of all, I appreciate all our participants for choosing various aspects of relevant topics and presenting them in a good manner. And it's incomplete without showing gratitude on our faculty board. I take this opportunity to thank each and every faculty for the guidance. And we hope this presentation definitely made sense. Learn a lot during these 3 days. And we make sure that soon we'll be back with a next series. So until then, goodbye and thank you all.